Welcome to your renal rotation at Ktph. Look, we get it. The learning curve can feel, well, pretty steep. So we put together this survival guide to help you hit the ground running. We're going to kick things off with a topic you will see from day one, glomerulonephritis, or GN for short. Let's dive in.
So picture this. It's your first day on the job, the phone rings, and it's a consult for potential glomerular disease. Your heart might skip a beat, right? But don't worry. The key isn't to know everything, it's to have a clear clinical map. And that's exactly what this is, your step-by-step guide to finding your way.
And here is our map for today. First, we'll get a lay of the land with the GN landscape. Then we'll get into the nitty-gritty of the two most common referrals you'll face, the hematuria workup and the proteinuria puzzle. After that, we'll ramp it up to cover the emergencies, and finally we'll talk about getting the definitive answer with a biopsy and what happens next. Let's start with the big picture.
Okay, first things first. Here's the good news about glomerular diseases. They tend to show up in a few classic ways, what we call clinical syndromes. Your single most important job right at the beginning is to figure out which syndrome your patient fits into. Nailing this step is going to guide everything you do next.
So let's start with a classic scenario, something you'll see all the time. A GP refers a patient for asymptomatic microscopic hematuria. This is your bread and butter. The patient feels totally fine, but their urine dipstick keeps showing blood. What's your first move? Where do you even begin?
You've got to be systematic here. Step one, and this is key, think outside the kidney first. Could this be from a gynecological issue, urological? Could they have just run a marathon? Once you've considered that, you move to step two, the formal urine test, or UFEM. Then, based on risk factors, which we're about to cover, you'll decide if they need a urology workup before you even think about circling back to the kidney.
Now, this part is absolutely crucial. We cannot afford to miss a urological malignancy. This table lays out the red flags that should automatically trigger a workup. If the patient can see blood in their urine, if they're over 40, especially a male smoker, or they have any of these other risk factors, it's an immediate workup. Think of these criteria as your safety net.
Okay, now for the real detective work under the microscope. This is a huge fork in the road. Think of it like this. Are the red blood cells looking pretty normal or isomorphic? That suggests they probably came from somewhere downstream like the bladder. Or are they dysmorphic, all beaten up and misshapen? That means they've been squeezed through a damaged, inflamed glomerulus. Now be careful. A really aggressive GN can bleed so fast the cells look normal. But the absolute smoking gun, acanthocytes. If you see those little Mickey Mouse cells, you've pretty much found your glomerular source.
All right, that's hematuria. Let's move on to the other really common consult you're going to get, proteinuria. The story often starts with a simple complaint from the patient. Doc, my urine looks really foamy. Our job is to take that clue and solve the puzzle.
So, how do we actually measure this protein? Well, the dipstick is just a rough screen full of false positives. The 24-hour urine collection, it's the gold standard, sure, but it's a massive pain for the patient. That's why, for most cases, our practical go-to test is the spot urine protein to creatinine ratio, or UPCR. And here's a great little clinical pearl for you. That foamy urine the patient is so worried about, it only points to significant proteinuria in about a third of cases. It's a useful tidbit for patient counseling.
Okay, so you've got the UPCR result. Now what? Just follow this pathway. If the protein is low and it comes and goes, you can probably just monitor things. If it's low but persistent, the risk for chronic kidney disease is higher, so we start thinking about an ACE inhibitor. But once you cross that 1 gram per day threshold, a renal biopsy is seriously on the table. And then, look at that box on the far right. If you have any proteinuria combined with blood, high blood pressure, or a rising creatinine, that's the stop everything and do a full investigation box.
We've been talking about the common stuff you'll see in the clinic. Now we're going to crank up the intensity and head to the wards for the real emergencies. This is where you, the MO, can make a huge difference by identifying these conditions quickly.
The two big syndromes you need to burn into your brain are nephrotic and nephritic. Just think of it this way. Nephrotic is leaky. It's a leaky filter. You get massive protein loss, tons of edema, and low albumin. Nephritic, on the other hand, is inflammatory. The kidney's angry. You see those dysmorphic red cells, kidney function starts to drop, and blood pressure goes up. Knowing the top causes for each one immediately helps you start building your differential diagnosis. Among all the acute presentations, this is the one that should set alarm bells ringing: rapidly progressive glomerulonephritis, or RPGN. This is a true medical emergency. We're talking about kidney function that just plummets over days to weeks.
If you see a patient's GFR taking a nosedive like this, you have to suspect RPGN and you have to act fast.
When you suspect RPGN, this is your stat lab panel. You're basically hunting for the big 3 culprits. You'll check ANCA antibodies for vasculitis, you'll check anti-GBM antibodies for Goodpasture's disease, and you'll run a full lupus panel. But here's a super important point. A negative ANCA test does not rule out vasculitis. And always, always consider mimics, which is why you'll check a blood film for any signs of hemolysis.
Okay, so we've gone from symptoms to syndromes, we've checked the blood work, and now for many of these conditions, it's time to get the definitive answer. And that means getting a piece of the kidney itself with a renal biopsy.
Getting a patient ready for a biopsy is like a pre-flight checklist, and your role here is mission critical. Now, the consultant will take consent, but you need to make sure the anticoagulants are stopped, the labs are up to date, and the blood pressure is controlled. We cannot safely biopsy a hypertensive kidney. And here's a bit of local Ktph knowledge. We schedule these before 10 a.m. to make sure that specimen gets transported to NUS for processing the very same day.
So the biopsy is done. Now it's all about monitoring to catch any complications, especially bleeding. And we've got a super simple acronym to help you remember what to do. CRIB. C is for lying flat on their back. R is for repeating the FBC. I is for inspecting every single urine sample for visible blood. And B is for frequent blood pressure and vitals monitoring. CRIB. It's an easy way to keep your patient safe.
Once you have that biopsy result, it's time for treatment. It's helpful to think about it in 2 big buckets. First, you've got the generic supportive stuff that pretty much everyone gets, like an ACE inhibitor to reduce protein loss and really tight blood pressure control. Then, for the immune-driven diseases, you move to bucket number 2, the heavy hitters, the immunosuppressants. You'll get very familiar with all of these names.
And listen, treatment is so much more than just writing a prescription. A huge part of our job is patient education. This quote from the guide is just golden. It's a perfect example of the practical, real-world advice you'll be giving. We're talking about everything from avoiding certain foods to prevent infections to crucial advice on contraception for both men and women on certain drugs. This is the human side of nephrology, and it's incredibly important.
So let's wrap this all up. What's your role as the new medical officer on the renal team? It really boils down to this. Identify the clinical syndrome, follow the diagnostic pathway, and know the red flags to tell you it's time to biopsy. If you can master these fundamentals, you're going to be a fantastic asset to the team. We're happy to have you. Welcome.